Okay, let's go ahead. Let's do the cahoots. Remember, I can't give you any of the exam grades until Saturday. But as I said before, some of you came on, everybody passed. It went from 78 up to 96 or 8, one of those. Okay. And I think one question was coming back, and that, took into account for those grades. So good job, everybody. You listen, you do what you're supposed to do. You're listening to what I'm telling you. So awesome. So let's go ahead. Let's do our cahoots. Who wants to win tonight? And remember, this is, you just studied for an exam. How many of you really have looked at this week's information? Now, have you seen it in MedSearch 2? We're about the same topics right now. This week we're going to go over the child with cerebral dysfunction, and we're going to go with endocrine dysfunction. And it's hard to do it over a cahoots, but I'll do it. Week 7, guys, it's amazing. Remember to give me the names of what your diagnoses are. I don't want everybody with ADHD. I don't want everybody with asthma. I want a variety. In fact, I love it when you teach me. Teach me something I don't know. Yes, I'm a nerd. I know. I heard from your dean this morning on our at-risk call that she went into one of your classes, and some of you were telling her, we need Professor Bogart to come teach on ground. I'm only 9 miles from the school. So what do you want me to teach?
MedSearch.
I agree. Everything at this point.
Oh gosh, you're too kind. You're too kind. Listen, if you need help with anything, you're always welcome to come to me. I can teach you what I know or try to figure it out with you, but I'm always willing to help, okay? Let's go ahead. Let's get going. Let's get out of here tonight at one point. Week 7, cerebral or endocrine dysfunction. It's a combination. Remember, I change them every quarter, making sure you get what you need. So growth hormones is administered by what route? Remember, these children are small, and children have to take on this thing where they have to give these children medicine every day for years. So they have to be compliant, right? So these growth hormones are not easy. It is like giving insulin every day. So some of the older teenagers, like young teenagers, that 11, 12, 13-year-old that's like 4 foot nothing that wants to grow a little bit, every day has to give himself usually a subcutaneous injection. It's like giving insulin. So think growth hormone, think insulin, sub-Q. Highest priority for a patient diagnosed with syndrome of an inappropriate antidiuretic hormone. Now, take the word antidiuretic, against urinating hormone. That's all it means. If you're against urinating, what are you doing? Think about the words, and then you can answer and you know everything about it. This is a child that you are going to be monitoring intake and output, because if they're not urinating, we want to see how much weight are they gaining, right? How much fluid is accumulating. Which of the following are signs and syndrome of an inappropriate antidiuretic hormone? Again, what would you see? A child or an adult is not urinating the way they should because this hormone is doing that. What would you see? Well, I know they're going to be gaining weight for sure. And you're not going to see any urine against urinating hormone, right? Makes sense. Don't take these big words and go, oh my God, I have no clue. They're very easy. Pull them apart. Which is important to cover when teaching the family about polypropyl. Now, this is a a hormone that's given for hyperthyroidism. And it's one of the warnings that on discharge teaching, we need to tell them. And it's actually, there's two hormones, and they both actually have the same warning. And the problem with getting that thyroid to slow down, stop producing thyroid, it also causes leukopenia. So if you have a fever or sore throat, you're sick, it could be because of maybe too much of the medicine. So this is something that we would call our physician with. A multi. An initial sign of diabetes insipidus. Now, diabetes insipidus has not a darn thing to do with blood sugar. And I'll say it 3 times. Insipidus, even though it's diabetes, has nothing to do with blood sugar. I can't tell you how many RNs would bring me a child with diabetes insipidus and tell me what their blood sugar was. And I'm like, so why did you do that? It has everything to do with fluid volume. All fluid volume, which means this pituitary gland, the posterior pituitary gland, secretes its hormone. And what it does, it says urinate, urinate, urinate. And you're thirsty, thirsty, thirsty. So, and it doesn't matter. You drink, and you urinate, and you urinate. And that is the 2 signs of diabetes insipidus. It's the pituitary gland. A multi. What are the clinical manifestations of juvenile hypothyroidism? They're all the same as an adult, except one thing. Children need everything and all the hormones they're getting because they need to grow what they need to grow, right? So that's why we do height and weight for every visit on any child. So it's the growth, which is the difference. Dry skin, sparse hair, constipation, cold intolerance, these are all adult, but they're also with children. And the one thing that's added, they're not going to grow because they need the hormone to grow. A child had a simple febrile seizure. What education would you provide to the parents? My oldest grandchild had a febrile seizure about 12, 13 months. And let me tell you, his mother has become a fanatic with a thermometer. And these kids are 11 and 9 now. And she's still taking temperatures. The problem with having a febrile seizure is you can't stop it. I mean, you could take the temperature as much as you want. Like my daughter-in-law, I mean, she is like OCD. Now, he never had another febrile seizure, but once you see your kid having a seizure, you're really concerned. And it's always with a seizure, it's always safety, which means turn them on their side in case they vomit. Don't try to shove anything in their mouth. And protect from injury. That is all about seizures. What type of seizure is when the body's jerking, foaming at the mouth, and the child is rendered unconscious? This is different from febrile seizures. Febrile seizures are usually pretty quick. This one usually goes on longer, and it's a tonic-clonic. When you think of grand mal, tonic-clonic, this is what it is. The whole body's reacting to it. And usually they're a little bit mentally not there afterwards, postictal. What notable sign may indicate increased intracranial pressure in an infant? Now, infants can't tell you their head hurts, right? Now, vomiting might be one of them because of pressure in the head, but this one thing you'll never forget. They'll say that is a kid who's neuro, and it is high-pitched crying. This child could be crying in a room of 20 infants, and you'll say that kid is neuro. Something's wrong with his head. It is a different sound. And that's sometimes the way we see it. I mean, maybe the fontanelle's big and other signs, but that cry, you'll always remember. All of the following increase cranial pressure except what? Now, sometimes we get kids who are sick that's had Head injuries, we have to take care of them in the ICU. We need to know what's going to increase that pressure in the brain, and we need to know how to deal with it, right? So which ones increase it? Well, the tachycardia has nothing to do with pressure, but fluid and cerebral edema, that is a big thing. INO, daily weights on a child with any head injury, very important. Coughing, suctioning, turning, positioning, all of those things can increase it. So you're going to do like little bundle cares and try to do it maybe with a bolus of pain medicine before you do it, because you don't want to increase that pressure. What findings can alert you to a head injury that gets worse? The kid hit his head, sports injury, comes into the ER because he cracked his head, was unconscious a little bit, comes in, he walks in, and then what do you see that says something's wrong here? And they start to not think. Was I safe into third base? Did we win the game? Oh, did you tell me daddy's coming? Or did you get me something to eat? You'll see it over and over and over again. That's telling you there's pressure going on in the head. Pay attention to it. A multi. What does it mean when you see a fixed and dilated pupil after a head injury? Doesn't matter if a head injury falling off a second story building or just fell down and hit its head. It doesn't matter. You see a fixed and dilated pupil, this is especially if it's one and not both. If it's both, this child has massive brain injury and probably is not coming back from it. But one of them is telling you pressure is in the head and it needs to be relieved immediately. And we know that if that pressure continues, it causes brainstem damage, which is your heart rate, respirations, temperature. It's your body functioning. It's gone. So this child needs that pressure taken care of right away. They're not going to be around. What medication may be used for a child with cerebral edema due to a fall? Well, cerebral edema, swelling in the head, it's too much. You want a diuretic, right? To release the fluid. Which one is for the head? And that's how you would read that question. It's the mannitol. Remember, mannitol is head injury. Furosemide is usually peripheral or pulmonary edema, but mannitol is for the head specifically. So that's where that is used. What is Ray's syndrome? Children who have fevers, one of the things that we really need to make sure is the parents know it's only ibuprofen and acetaminophen, no aspirin. The only time we use aspirin, Kawasaki's, right? Because we want to stop the clots, etc. But any other time, no, because the fever's not going to harm them. Just take some clothes off, give them cool liquids, but never ever give aspirin. Febrile seizures usually occur in what age kids?
Oh, no. Febrile exposure.
It's about 6 months and about 6 years that it stops. And thank God now my grandson who had them is now turning 12, January 1st. So, I mean, he's beyond it, but I'm telling you, mom still has a thermometer. Childhood hypopituitarism results in which condition? Now you have anterior lobe, posterior lobe. Posterior lobe is all about fluid. Anterior lobe is all about growth. There's 2 lobes. So hypo, less than you need growth hormone, is a dwarfism. Okay, very good. Gigantism was when there's too much, and that's usually a pituitary tumor. How would you prescribe precocious puberty? Precocious puberty, what do you think that is? And again, these are hormones that are secreted, that's doing things that it shouldn't maybe do yet, right? Because precocious puberty is when you reach puberty early. Now, this is talking about little girls age 6 getting breasts. Can you imagine the teasing? Or even boys getting beards, believe it or not. And it's something that we don't want them to get until they're supposed to. So we can suppress it. And actually, you learned in pharmacology, it's called Lupron, that, suppresses that. A multi. What lab values are important to monitor when the child with congenital hypothyroidism, which means not getting enough thyroid hormone from birth? These children are usually constipated at birth. It's one of the conditions that you'll see. And next week, we're going to talk more about that. There's actually 3 different conditions. But when you're looking at any child or adult who has thyroid issues, you're going to look at T3, T4, TSH. Those are things we're going to monitor when you're talking thyroid. Growth hormone is pituitary gland. Cortisol is your adrenal gland, okay? So hypothyroidism, T3, T4, TSH. How can you monitor a child with hypo or hyperthyroidism? And it's something we do normally on children. We look at things that could be a pituitary problem, could be a thyroid problem. These different organs are dependent upon growth. And when we look at hyperthyroidism, are we getting enough? Are we tall enough? Are we too tall, too short? All of those things will make us look. Well, let's look at the thyroid gland. Let's look at T3, T4, TSH. Let's see if that's okay. Or let's look at the pituitary hormones. Are those things affecting it? And that can help us make a decision and help the child. What acid base alteration would you see in a diabetic child with Kussmaul respiration? When do you see Kussmaul respiration? Diabetic ketoacidosis. What are the lungs trying to do? Trying to compensate for metabolic acidosis. So when the lungs are trying to compensate, they go into respiratory, opposite from acidosis, alkalosis. The body is trying to compensate by doing the opposite thing, okay? So you're in metabolic acidosis, that is DKA. And respiratory alkalosis is trying to make it equal. The body's trying really hard to make it back to normal where it should be. A multi. What would a child with Cushing syndrome look like? Cushing syndrome, too much adrenal hormones. Are they endogenous or are they given orally? IV, IM. There's different ways to get these hormones. This is cortisol. What is cortisol? Cortisol is prednisone. So you get this big round face, red ruddy cheeks, you get hair, you get pimples, and you get fat in places all over. And that's from too much. Usually it's because, for instance, a child or me, a rheumatoid arthritis was given too much prednisone for too long. My face blew up. I went red and I was, more hair. I'm like, I chin on my chinny chin. I'm like, what's going on with me? And it was all due to steroids and Cushing syndrome. How do you reverse Cushing syndrome? You taper off the steroids, right? And then you'll go back usually to normal. A multi. You walk into a child's room, has a fever 104.6, and you see them have a seizure. What do you need to do? What's your priorities here? Kids having a seizure right in front of you. I mean, it happens to be due to a seizure. It doesn't matter why they had a seizure. What are you going to do for them? So, number one, turn them to the side. Always. If they vomit, it will come out. And usually suction is on the wall, so we're pretty good there. Always check the bed. You know, kids like to throw everything in their bed, and it could be sharp, and they could like be shaken, and it could cause, lacerations. Get it out of there. I just roll it out and throw it on the floor. Make sure there's side rails are up, they're padded. Whatever you can do to protect them, that's your job, safety. Take the pillow out, put them flat, turn them on their side, and protect and make sure that they're not going to fall out of bed. An autoimmune disease of the thyroid gland. And this is actually my daughter-in-law, the one with a thermometer. Autoimmune diseases, you can't remove them. And this requires lifelong monitoring of the thyroid hormones, T3, T4, TSH, and given different medications to equal yourself out. It is called Hashimoto's. You can't take the thyroid out in this case. It has to stay there. Hashimoto. Addisons disease. What's that? Opposite from Cushing's disease. What does that mean? It means adrenal gland. What does the adrenal gland do? So if Cushing is too much, Addison is not enough. So this is decreased secretion of cortisol and aldosterone. You see this a lot with this ambiguous genitalia, sex assignment things. And that's really becoming popular in documentaries these days. A multi-select, a ventricular peritoneal shunt, a tube that goes from the fourth ventricle behind the ear, down the front of the chest, into the abdomen. What do we think we need to do? What's going on with that head? These things could be a newborn child, an older child, and it's there because something's wrong. The cerebral spinal fluid doesn't drain properly. And if you have too much fluid, what happens? You get pressure. So it is usually started because of hydrocephalus. How do we, as a nurse, take care of it? Well, number one, you measure their head. Is it the same size every shift? If it's not bigger, something's going on. We don't touch. There's like a little pump valve there. Leave it alone. It's only for the neurosurgeons. And if we see a child with a VP shunt that's vomiting and a headache, probably it's disconnected. It is an emergency because now fluid's building up in the head. Probably needs to go to the OR for revision. Seen a lot of these in the ER. A common sign of Graves' disease includes blank or protrusion of the eyes. There's commercials on TVs now, right? About eye drops and the sunglasses. Have you seen it? And it's called exophthalmos. And it's just a term for you to remember. And they have eye drops. They're working on it now to make those eyes not so bulgy. A multi. Hypoparathyroidism has the symptoms of technic muscle contractions and blank. Now, the thyroid and the parathyroid are completely different. They're close to each other, but they don't regulate thyroid hormones. They regulate another element in the body, and that is calcium. Now, whenever you hear of calcium, magnesium, any question, anything about it, always think of muscle contraction. Both of those are needed. So Too much, you're going to have spasms or, tetany. And not enough, they'll be flaccid. Think about it that way. Calcium, magnesium. So not enough calcium, which is hypoparathyroid, muscle weakness, tetany, and you'll be at low calcium levels. How do you treat it? We give calcium. A multi. What are signs of hyperparathyroidism? The opposite way. Just think of a spasm on overdrive. Too much in there. And it's called the paresthesia of the extremities, but it also causes nausea, vomiting, confusion. So those are all part of it. It's hypercalcinemia, not hypo, if it's hyperparathyroidism. What does the parathyroid hormone do? Remember, parathyroid is all about calcium. Hypo, not enough. Hyper, too much. Which of the following might be a cause of an adrenal crisis or an Addisonian crisis? Remember, there's adrenal glands. We have Cushing's, we have too much, we have too littles. What is adrenal crisis? What is it all about? Usually what you see with an adrenal crisis is you have a patient, a child, an adult who's been on high dose steroids and they take them off and they don't taper, right? You need to taper them down. And if you don't, the body reacts and it could be very serious. You have tachycardia and, so a sympathetic nervous system goes bonkers if you don't treat it. Give some steroids, you treat it. A cardinal sign of diabetes insipidus. Diabetes insipidus, what did I tell you about that one? Posterior pituitary gland. It's polydipsia, polyuria. Now, you want to add on polyphagia? That's diabetes mellitus, okay? But diabetes insipidus, di, which is 2, right? Dipsia and uria. A multi. Congenital hypoplasia parent teaching should include. This is when you don't get enough adrenal glands. This is where you have a child who is born and doesn't have enough cortisol and aldosterone. And you're like, well, what are some things that can happen? And one of them is that they form different types of genitalia. It could be you have a penis and a vagina. You could have a penis and testicles. I mean, it could be all different things. In my career, I've only seen one. But what it is, the child is born and you go, well, is it a boy or a girl? Can you imagine how parents will feel? Is it a boy or a girl? Well, there's a vagina and a penis. I don't know. And then you have people asking. So number one, remember that as a nurse. But it's the child will never have children because they only have parts of either sex. They require a gender assignment. And then because of the adrenal hormone deficiency, they need cortisol and aldosterone replacements for life. And in times of stress, they need increased doses, okay? What causes type 1 diabetes? And I like this little thing. Bob is 36 candies, he eats 29. What does he have now? Diabetes. You eat too much sugar. Remember, diabetes is an autoimmune where the beta cells in the pancreas are destroyed, does not secrete insulin, and then the body says carbohydrates, I don't know what to do with you. So they just sit there. That's why blood sugars are up and urine is 4+ glucose. What statement about a pheochromocytoma is correct? An adrenal, it's a kidney adrenal tumor. What is it? What are we worried about this thing for? One thing about it, if we touch it, manipulate it, it could spread out little hormones and little spurts of it, and it causes a sympathetic type of thing, or catecholamines. Heart rate goes up, blood pressure goes up, and then you get these headaches and chest pain because heart rate's up and blood pressure's up, and they can't figure out why. These children, and along with adults, need to be looked at really closely. And if they're feeling these symptoms, we need to be checking those vital signs because we'll see heart rate up, blood pressure up, and it can maybe answer why, what's going on. And they just need to remove the tumor, and it's fixed. A multi. What action should the nurse implement in the care of a patient with a pheochromocytoma? Given what I just said, what are you going to do if you know it's a pre-op case? This child, this adult has a pheochromocytoma. What are you going to do? Well, number one, as I said, it's all heart rate, blood pressure, everything up, 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 up. We're going to monitor for high blood pressure, elevated heart rate, that chest pain, that headache. Glucosuria has nothing to do with the adrenal gland, and there's nothing to do with weight gain here. It's all about secretion of a hormone, which brings everything up, heart rate, blood pressure. And the treatment, again, is remove the tumor. A multi. Nursing care of an unconscious child should include what? And if you want to work in the newborn, pediatric, even the cardiac ICU, sometimes you have a child who's unconscious. What are you going to do? Well, we're going to, if they're there because of head injuries, we're going to monitor neurosigns, vital signs always. And if they're unconscious, remember, maybe it's head injury. Always worry about fluid balance with heads. Monitor strict I&O. And if you're able to weigh that child, you're going to be weighing them every day. What might you suspect if a child feels jittery, sweaty, and is dizzy? What are those classic signs of? Well, that sounds like hypoglycemia to me, right? Classic of it. Very good. Symptoms of DKA are diabetic ketoacidosis, diabetic sugar, ketones, acidosis, acid. There you go. Fruity, and that fruity breath, it smells like take a peach, put it in a Tupperware container, close it, put it in your refrigerator, take it out 2 months later, open it. It's going to be a sickening, sweet smell. That's exactly DKA. And I've smelt it over and over again with children because we close the doors at Miami Children's. When you have in the major ER in the main, we put them in, close it. You open the door and it's like, oh, this is DKA. And you know exactly what to do because of what? That extra sugar. It's oozing out of them. I mean, blood sugars can be at over 1,000 I've seen. And ketonuria, of course, 4+. Because why are ketonuria? Well, you're not getting sugar. Body's hungry. And the body says, let me eat fats and let me eat proteins. And the byproduct, ketones. And where do you see the ketones? In the urine. And that's why. A multi. An adolescent has a BMI above 95, has been urinating a lot. What test can you anticipate for this adolescent? What could this be? Their BMI is above 95. They've been urinating a lot. What do you need to do? We have an overweight adolescent. It already focuses towards diabetes. That's there. But always rule out a basic urinalysis. And if they're urinating a lot, check the potassium, right? The electrolytes too. So that was sort of that question on the side. Electrolytes also. Diabetic ketoacidosis is caused by what? I just said it. Doesn't like sugar, can't eat it, pancreas don't work, there's no insulin. So I've got sugar and then I have ketones. Why? It's because there's no insulin and the body says, I'm really hungry and I can't eat sugar. Well, what else is there? There's fat, there's protein. And what are byproducts of digestion of fats and protein? Ketones. Does that make DKA sound easier than what you're thinking? All it is I can't use sugar. I got to eat something, so it spills it out. And all of that causes the pH to drop. Okay? A multi. A child's admitted with blood sugar greater than 600 and large ketones in the urine. What's the first thing you need to do? Number one, what do you have to do? That blood sugar is greater than 600. Number one. Number one, you need to dilute that sugar in that body. You need to give fluids. And on the other hand, you're going to have a regular insulin, slow titrated drip. You never give sub-Q insulin for DKA. That's too long. It's unpredictable. You don't know when it's going to work. It is that regular insulin, slow, continuous drip. But number one, priority is that IV bolus and normal saline, no sugar. And of course, we know the potassium is going to have issues. So we're going to watch those potassium and seeing when we need to give it. A diabetic child complains of feeling jittery. Blood sugar is 45. What is the best treatment for the child? Look at the question before you react. The child's complaining of feeling jittery. So if they're complaining, what are you going to do? Give them orange juice, give them milk, give them sugar, give them something, and that's going to help them. Very good. Again, remember, read the question. Your patient has experienced a head injury. What would most concern you? With everything you've learned off of this cahoots today, if you have a head injury, what there is going to say, we have a problem. What's the biggest thing with head injury, right? Swelling. What does swelling do? It squeezes the pituitary gland. It can't work. Decreasing urinary output. That is a huge concept, okay? You're going to see that in med-surg too, guaranteed. A multi. How do you detect diabetic ketoacidosis? So DKA is high blood sugar, ketones, and glucose in the urine, right? And most likely this kid is going to look pale. Actually, it's going to look dehydrated, okay? That's why you're giving that bolus. And they're almost like not alert. Once you get that bolus in them, get that blood sugar out, they pink up and they look great. Many times parents will wheel them in a wheelchair. And that's what they look like with really DKA. Blood sugars of 600, okay? Or maybe 1,000. I've seen them. What would alert you that a child's head injury is deteriorating? So you've got an injury, swelling's going on. What are you going to see? Well, not urinating is not there for you. What are the other things? So the child's going to get confused, asking the same questions. Then it's going to get to the child where they're restless and hard to arouse. And the headache is going to get worse. And another thing is they're going to start vomiting, and it has nothing to do when they're eating. So if everything progressing is getting worse, that is telling you something, there's pressure in the head. We need to do something. A child's been diagnosed with bacterial meningitis. What is the nursing priority of care? How do you diagnose bacterial meningitis? Do you know? It comes in, fever, maybe neck rigidity, headache, pain, crying, that neuro cry. You do a lumbar puncture. And the lumbar puncture is going to show bacteria in there. And it's going to look not clear, that cerebrospinal fluid. It's going to be almost milky-like. And it's white blood cells and bacteria in there. And your priority is antibiotics. Antibiotics and antibiotics. Keep that fever down for the poor kid. What is the primary cause of injury associated with submersion? Drowning. You live in South Florida. You need to know this one. I've seen a couple drownings in my life, and I've not seen really good outcomes usually. If they're down, they're sitting there. Usually if they come up, they're not going to be neurologically the way that they were, because that fluid fills up the lungs. There's no breathing, so it is hypoxia. Very good, guys. And last question. A multi. Which CSF lab value correlates with bacterial meningitis diagnosis? This is a MedSurg 2 question. Do you know the answer? What do bacteria like? They like to eat. What do they like to eat? They like to eat glucose. And what do they leave behind? They don't like protein. So low glucose, elevated protein. You're going to see increased white blood cells in there, not decreased. So does that make sense? Let's see how we did. Number 3, Amy. Good job, Amy. This wasn't an easy Cahoots. Number 2, John. Good job, John. Good job. Number 1, Yadi. Good job, guys. Number 4, Smile and Danae. You know, this was a hard one. A lot of interesting, information here. Hard to understand. I mean, it's only because that you have already done MedSurg 2 and have heard a lot of it that you get it. So anyway, any questions for anybody? Remember, send me your diagnosis you want, okay? And I will be posting these grades by about 2:30 on Saturday. Okay? Thank you, everybody. You have a good night.
Professor, how do you want us to send? How do you want us to send it to you?
So what?
For the project, like our topics.
Send me a message in Canvas.
Okay.
I want to do this topic. And I get back pretty quick. I have
Okay.
it on my phone and I look at it, frequently. Even if I'm by the pool or here or there, I'm always checking, looking. So just let me know. I'll let you know pretty quick.
Okay. Thank
Okay.
you.
You're very welcome. Good night, guys.